Hi, my name is Khalid Sharif. I'm a consultant orthopedic surgeon with an interest in sports surgery, and today I'm producing a video on full thickness rotator cuff tears. This is especially important for overhead athletes. I draw your attention to a link for a video I've done before on partial thickness rotator cuff tears. So please do have a look at that because it complements this video. Anyway, so I'm going to be speaking about the anatomy. I'll speak about the causes of cuff tears, the presentation, the prevention and treatment. We're going to cover the whole subject. So please, if you do like the video, then give it a thumbs up, share it, prescribe to the channel, because I'm going to produce very many more videos, and so that you can have access to them, do prescribe to the channel. And also leave me some comments if there are any further subjects and injuries you want me to address in the channel. So let's dive in. So the rotator cuff is a set of four muscles. They are the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. And their function is to stabilize the shoulder joint and to lift the arm up, and also for external rotation, internal rotation. So basically movement of the shoulder is dependent on the deltoid and the cuff muscles. And they are the heart of the shoulder. Their function is very important. So what are the causes of rotator cuff tear? So repetitive overhead activities and aging. Now, trauma, there is controversy on whether the trauma will cause a cuff tear. In my view, I've faced this a lot in my medical legal practice. Somebody's had a fall and they do an MRI and they discover there's a rotator cuff tear, and is it the cause of the fall or not? In my view, a normal cuff or a normal tendon, for it to tear from low energy trauma, non-penetrating trauma, is rare. Usually there is an aging process that's already in place, or there is a small tear and the trauma caused it to become worse. So I get a lot of patients come in and they come with pain, and you MRI their shoulder and you find a cuff tear. Or sometimes, actually, if it's been proven in research that if you do an MRI scan for people with no symptoms, you can sometimes find a cuff tear, and that incidence increases with age. So some studies have shown that those over 80% will have a cuff tear of some sort. So we have to be careful when we allocate the causes for shoulder pain to a small cuff tear. Now, the symptoms usually they come with pain at night, pain when sleeping on that side, pain with overhead activity, and the signs. I mean, there are lots of signs. It's outside the remit of this video, but in any case, you will get weakness with overhead activity, weakness with resisted or pain with resisted abduction, but you can get impingement signs like the Hawkins sign, and you can get usually a lot of the times I've seen it being associated with long head of biceps tendinopathy. So you will get tenderness over the biceps, a positive speeds test. So there's a lot of signs involved here. The diagnosis is with an X-ray won't show you very much unless it has caused arthritis in the shoulder, or sometimes when it's a chronic and massive rotator cuff tear, it will cause the head of the humerus to ride up in its socket. Now, the important diagnostic test is the MRI, and that's the gold standard. You can have an ultrasound scan, but that is operator dependent. The advantage of the MRI is it will show you the quality of the muscle, and that guides the treatment. It's very important to see how much fatty infiltration there is in the muscle and the quality of the tendon, and that's the advantage of the MRI over the ultrasound. Now, the prevention of rotator cuff tears, I always advise athletes to do stretching exercises, and that can be sort of scapular retraction and stretching across a door frame, so to hold the door frame and lean into it. There are strengthening exercises also, external rotation, resistance bands, scapular retraction exercises. These are very important. Also, to actually work up into the athletic activity gradually, to have a proper warm-up, to have a proper cool-down. Also, you have to have a balanced workout of your rotator cuff of your shoulder. I've seen a lot in the gym where I go, these weight trainers, they come and hold very big weights and they're sort of struggling to lift it up like this, you know, and I think I always advise them that's not a good idea. You have to have a gradual progression and not to overload the cuff with these exercises. So now we come to the treatment of the cuff tears. A small cuff tear, I always start with conservative treatment: physiotherapy, non-steroidal anti-inflammatories, stretching exercises. I will give a steroid injection in the instance where they cannot tolerate the physiotherapy without a lot of discomfort. And generally I tend to avoid it if I am planning to repair the cuff, because there are studies to show that it increases the incidence of infection and it will affect the healing rate of the cuff. Now, PRP injections, whereas steroid injections have a short-lived benefit, PRP injections, some studies show that it's better. They can improve the healing of the cuff and also reduce the pain. However, I will advise them for tendinopathy and partial thickness tears, not for full thickness tears. I don't think there is any role for PRP injections on full thickness tears. You can use PRP injections post-repair, and there are a lot of studies to show that it improves the healing rate. But here I must stress the literature and the research out there are mixed in their conclusions, and the reason being that the different preparations of PRP injections that are used, the different rehab techniques, the different repair methods that are used, so it's difficult to actually generalize. I think more studies are required on that view. Now, what about the outcome of surgery? So the surgery can be arthroscopic or open or mini open, and there are ways to do either a double row or a single row repair where we use anchors and sutures to repair the tendons. And I've done a lot of these operations with very good results. Usually we do a subacromial decompression at the same time, which is to shave the hood of the acromion and smoothen it to improve the outcome of the repair of the cuff. The outcome of the surgery depends more on the quality of the tendon that you have started off with. That's why you have to assess the patient properly. So if you have a cuff with a lot of fatty degeneration in the muscle, the bad quality of the tendon, very large tears, patient with comorbidities, diabetics, the blood supply to the cuff is very important to control the outcome of the tear, of the repair, and the re-tear rates. There are re-tears. You could repair the cuff and it could re-tear in some cases if the quality of the tendon is poor, and if the blood supply is not so good, and there's a lot of fatty degeneration in the muscle. I do advise people. I mean, there's a lot of questions that come up to me and they say, oh, I've got a small rotator cuff tear, and is it going to progress, or do I have to have the surgery? And there's a lot of research on there. My advice would be for if it is in the dominant hand and it's painful, then I advise repair, especially if it is a significant size tear and there is good quality muscle, because in that scenario, the progression of the tear has been more frequent than otherwise. I hope this is helpful. Thank you very much.